Hello, everyone. Good afternoon, morning, evening to you all. Thank you very much for coming for today's meeting. If you're not speaking, if you can mute, please. Yeah, so thank you very much. We've had quite a few busy weeks, but we are getting there. We're starting data collection on Monday. So we thought we might just have this meeting with you and then go through a few things. We're going to record this. We're going to record this session and we'll take questions at the end. But if you have any burning questions in the meantime, just put it in the chat. My name is Teddy. I'm a clinical research fellow with the Global Surgery Unit, University of Birmingham. So really today I thought we'd go through two main things actually, the mini teams registrations, and then also would have a look at the data collection tool you will be using. So those are the two main things. So we'll quickly go through the CRFs and then we'll answer your questions after that. Some important things to highlight is the fact that, yes, we are aware a number of you have not had your mini team registrations. We plan to get all that sorted. For those who have been registered by your hospital leads, you should have your logins well before Monday. But then in the off chance that you don't even get any logins at all before Monday, it's not the end of the world. Once you have approvals in place, you can use the data collection tool, the paper CRF, to take that down. And once you have your logins, would give you can transfer them onto RedCap. What we'll be doing today is to go through the entire CRF for both the main cohort study and then the sub-studies as well. In addition to that, we'll be providing videos, very short videos, going through the data collection process, and then also a data dictionary, also for the main study and then also for the sub-studies, so that you can go through these whilst you collect data. We would have regional meetings, drop-in sessions, weekly sessions where people from different regions of the world, you would have separate sessions for you where you come, and then if you have any peculiar problems you'd want us to address or troubleshoot, we'll do that. So this won't be the last meeting. This is just a first one where we try to kind of go over everything, and then subsequently we'll have these regional meetings where you can ask specific questions. Without taking much time, I would hand over to Mohammed El Hadi to go through the data collection tool. So Ellie, if you can allow Mohammed to share his screen, that will be great. I'm going to stop sharing now.
Yeah. Hello, everyone. Nice to see you today. I'm Mohammed El Hadi. I'm a junior doctor working in Libya. Thank you, Teddy, for the nice introduction. Today, we are going to go through the CRF, which is the data collection sheet, and I will try to explain how to enter your patient data in this RedCap. Let me try to share my screen. Yeah. You see my screen now?
Yeah, we can see it, Mohammed.
Yeah, okay. So the first thing is, once you log in into your account, as you know that you will get your RedCap account for each member of your team. So they have to see this page here. You can see that Alligator main data collection. So you have to enter through this. And once you enter here, if you would like to add a new patient, you have to click here, add or edit record. If you have an existing patient that you would like to edit, you will see it here. So here you will see your patient that need to be edited. For example, if you'd like to add some data point or edit something that you entered incorrectly or follow up, or etc. So if you would like to add a new patient, you have to click here, add the new record. First of all, you have to get this to starting page. You have to ensure that you have all the permission or the approval in place. So you have to click yes. If you don't have, you have to click here no. Then you have to enter the data collection window. As you know that we have several data collection period to enter from. So you have to enter the one that you have collected this patient on, i.e. that means the time that patient was operated on. Let's say, for example, we would like to do this as a test. We will choose this period 2. Is this patient enrolled in sub-study? So as you know that Alligators is not only about collecting just patient for appendicectomy, we're also collecting other data that will help us for more sub-studies. So if you would like to involve in these sub-studies, please click yes. If no, you have to click no. So in this case, we will click yes. And you have to click this as complete, so it allow you to enter to the next form. So you can see here that now we have like 5 other forms that we have to enter for each patient. We have demographic, presentation on this episode of care, intraoperative, follow-up, sustainability. So let's start by the first one, which is demographic. So you click here, you have to enter the patient age in year. Let's say, for example, we will put like a testing patient as 28, okay? So we will 28, let's say, for example, male. So you have to click which comorbidities or diseases that these patients have. Let's say, for example, like diabetes, and you have to enter the ASA score. As you know that this is American Society of Anesthesiology score to assess the patient. So let's say, for example, grade 1, so it's healthy, or maybe grade 2 because it's diabetes. Okay, we'll manage it. So does this patient have any previous abdominal surgery? Let's say no. If you say yes, it will put this or minimal invasive like previous history. So no. Was this a previous episode of right iliac fossa pain leading to hospital attendance within previous day? Because sometimes this patient was appendicitis as a suspected. Sometimes it was maybe managed conservatively, or given antibiotics or etc. Or maybe the patient was attended previously but wasn't able to afford the surgery. So you have to make sure that you enter this correctly. If the patient has like came to the hospital with the same issue with right iliac fossa pain. So in this case, let's say, for example, say no. So was like no, this patient hasn't come in the previous 30 days. And you have to click complete. Once you click complete, you have to click here, save and exit to ensure that you have entered thing correctly. You see here that green, that means you have entered thing correctly. If it give you like different color, like red or something, that means something is wrong or something not corrected. So you have to enter now the symptom at presentation. So let's say the patient have like nausea, vomiting, right, iliac fossa pain, these usually loss of appetite, for example. These would be like the main symptom of presentation. So you have to click them. Then you have to sign what sign of patients that have. Does the patient, let's say, have right iliac fossa tenderness, was like, for example, like Rovsing sign positive, has some fever, for example. You have to tick this as per patients, okay? So if the patient has like attended the hospital, has the patient maybe seeked any other type of treatment anywhere before attending to hospital, whether from traditional here, as in some area, community health, was maybe referred by a primary doctor, for example, let's say no.
The meeting now? Oh, right. Sorry.
Okay. So what this next question is the time from the symptom to first assessment, because as you know, some patients may have like bearing this pain for 2 or 3 days, maybe less or something. Let's say, for example, within 24 hours. So the patient has this pain or this things like within 24 hours from symptoms to assessment by the surgical team. And if the patient has arrived in the hospital and the patient has assessment, what the time that the patient need to get to the theater. For example, let's say within like maybe 10 hours or something, because the patient might not be able to enter to the theater immediately. And if the patient has any some sort of appendicitis risk score. As you know, there is Alvarado score, which is very known by many people, or any other appendicitis score. If the patient has this score, you have to enter. For example, if you enter here Alvarado, for example, score, and if the patient has undergone some sort of imaging, whether ultrasound, CT scan, MRI, and if there's like some blood test, let's say that the patient has like ultrasound but was like equivocal result, let's say, and then has a CT, which is like confirmed appendicitis. Let's say that, okay? For MRI, usually it's not done specifically for like some other countries. Then if the patient has any sort of blood test like C-reactive protein or white blood cell, you have to enter the value here, like in milligram, okay? And white blood cell, with what's the patient range? Let's say, for example, 50, or like as an example, okay? If none, you have to choose none. What was the main surgeon who reviewed this patient before surgery? Whether it was done the surgery by like consultant, or maybe someone with like registrar or resident on training, or etc. Let's say, for example, this one, doctor with less like 3 years of experience. And then you have to click complete. Then at the same as we say, we have to click save and exit. Okay. Moving to the next section, we will go to intraoperative CRF. In intraoperative CRS now, what's the main surgeon that's covered in, or the most senior one? Let's say, for example, like someone with 3 years of experience. What's the time of knife to skin? Whether this patient, it depends on the time of presentation and the time of entering theater. Let's say, for example, this one from 6 p.m. to about 12 a.m. Okay. What was the approach, whether it was open, and what type of open, or laparoscopic that was converted to open, or robotic? Let's say, for example, laparoscopic. Okay. Was any other procedure done? What, for example, like right hemicolectomy, resection of Meckel diverticulum, any small bowel obstruction, or sorry, resection, etc. So let's say here we will choose none. Then after that, was that what's the gross picture of the appendicitis at that time, or the appendix? Was it normal, or some appendicitis, or complex, like there was gangrenous or porphyry? Let's say, for example, complex appendicitis. And if the patient has received any type of antibiotic, whether it was preoperatively or at induction of surgery, etc. Let's say, for example, preoperative. And if there was like some sort of power outage, it happened in a lot of areas, especially in some countries. For example, it happened also in Libya. So was there any power outage that has happened during the theater? Let's say no, for example. Okay, everything went smooth. So you have then click save and exit form. Then moving to the follow-up. Follow-up here, we will see if the patient has given like antibiotic post-operatively. You have to choose yes. What was, or when was they administered? Let's say within like less than 24 hours. Was there any type of surgical site infection within 30 days of surgery? If you say yes, for example, whether the patient has done reoperation, the patient was readmitted maybe for any other reason later, you have to choose yes. But now we will choose no, okay? Then we have to determine the complication grade, which is based on Cleveland-Endo complication. Whether the patient, as you can see here, that it's very known grade classification, like grade 1, 2, 3, 4, 5. So one like deviated, like for example, patient take like analgesia or antibiotics or diuretics or anything. The second one is the patient has taken more drugs for specific something that's more serious, like surgical site infection or myocardial infarction, or etc. Grade 3, the patient required some sort of surgical, whether it was like reoperation or something. And grade 4, the patient has like complication that needs critical care management, like renal failure, mechanical ventilation, etc. So let's say for this one, we will choose just grade 1 or no complication. Let's say just grade 1. Okay. Now, what's the length of hospital stay? The patient has, of course, maybe stayed like, let's say 2 days, okay, in the hospital. So you have to enter that, okay? And if the patient entering, like, if your patient still at the 30 days for any reason, if the patient still at 30 days in the hospital and was not like discharged, you have just to enter 30, okay? And if the patient, as we say, has readmission, let's say no. And you can see if you put yes, the patient, that it will give you like an option to put how many days the patient has been readmitted. In this case, we will choose no. Now, as you know, there will be like histopathological examinations for the specimen. Let's say that there was like complex appendicitis, gangrenous or perforated. Okay, you have to choose the histological part. And the most important thing is here. For any reason, if you find this patient is not eligible based on the study criteria for any reason, or if you, for example, you are working as a team, someone of the team has included this patient and you entered that the same patient, so it was entered twice, so you have to exclude that. Okay, so you have to enter this one. If your friend or colleagues has entered the same patient, you have to choose no, so we will exclude that automatically. If the patient doesn't meet criteria, you have to choose this one. If the patient was like, as we know here, it's not a real patient, so it's just a test, so we will choose this one, for example. Or you have to choose this one for any other reason, okay? So in this one, we will like, because it's a test, we can do this and complete, okay? Because it's just a testing patient. Now, the additional part of the study, which is about the sustainability. So this one is for like more sub-studies, which more will be like more additional paper that we will work on after the main project. So the first question here is, what was the professional background on the anesthesiologist or anesthesia provider that was working with? What was it, whether it was nurse practitioner, for non-physician, physician-like, or like anesthesiology resident or registrar, or like consultant. Let's say that was consultant, okay? What was the mode of anesthesia? Let's say, for example, general inhaled, okay? And you have to choose which type of inhalation, okay? Or if you put like total intravenous, you have to choose which one. We will just enter like any like sevoflurane, for example, and propofol. That's just an example, okay? So the next thing is, what was the disposable or reusable equipment? So you have to put which one of these that was disposable and which one of these that was reusable. So for example, needle, syringe, endotracheal tube, let's say single use, okay? No, sorry, I didn't. Okay. Laryngeal mask, let's say, for example, face mask, stylus, forget, breathing. So you have to choose which one was like with this reusable ECG leads, pulse oximeter, blood pressure cuff, temperature probe, etc. You have to choose which one is reusable, which one as just single use and disposable, and single use and re-sterilized. Okay. Then you have to choose which, the same thing for the instrument. You have to choose which one, and other things for the other like more surgical instruments. Okay. Then you have what was, if they're like solid waste produced during the procedure, was it collected all together? Was it differentiated into clean and contaminated, or it was like put in as differentiated into clean, contaminated, and collected like separately? So you have to choose which one. Let's say, for example, the first one, you have to choose this one if they were collected together, and you have to click here as complete. Okay. So we have now entered all the available patients, and of course you can return to this form. So this form record or this patient record is 28. So my advice is, if you are collecting on paper, you have to put this, like if you are collecting this patient on paper, you have to put record ID 28 on the paper. So in case of if you would like to return to the same patient, edit some data, remove this patient or exclude it, you are able to do so. And as you say, if you would like to edit this patient or any other patient, you have just to click here, add or edit record, and you have just to choose which patient, which here, for example, 28, and you will just wait and it will return back to 28. If you'd like to add or edit other patient, you have to do the same thing. So this is the main idea of how entering the patient's data and how to edit them. And I hope everything is clear. And of course, if you have any questions, please feel free to put in chat, or maybe if Teddy allow to raise your hand if you wish. Okay, thank you so much.
Yeah, thanks, Hadi. That was very good and clear. Just to add to what Mohammed just went through. So if you'd all remember, we have two sub-studies. We have the waste management and sustainability sub-study, and then we have the finance sub-study. So the sustainability and waste sub-study is open to everybody across the world. Whichever hospital you are in, you are eligible to take part in that. It is optional, but it's open to everyone. The second sub-study, which is a finance one, is only open to 7 countries. So Ghana, Benin, Nigeria, Rwanda, South Africa, Mexico, and India. These are our NIHR hub countries, and they are the only ones who can do the finance bit. So if you are out of these countries, you will not have the finance bit open or available to you to complete. So I'm just going to go through the finance bit briefly. It's a very short form, but that is only open to the 7 countries I just mentioned. But then the waste management and sustainability is open to everyone. So the finance bit really is looking at what kind of, or what are the costs from a patient perspective when they come to the hospital and undergo either minimally invasive or open appendicectomy. So the first question is asking where or what covers the cost for the patient. Is it from a public insurance, private insurance, or is it the patient's paying out of pocket for this? If none of these options apply, you have the next box to fill in exactly where their payments is coming from. And the next question is asking, for example, if a patient has had a combination of sources or combination of funds to pay for their care. So in certain countries, you might have maybe government paying part and then the person paying out of pocket for the rest. So this question is asking which of the options or which of them covered the most of the care. So if, for instance, the patient coming to the hospital, let's say in Ghana, for instance, a patient comes to the hospital and then their cost of care or their bed is paid for by the health insurance, the national health insurance, and the operation is paid for by the health insurance, but then everything else is paid for by the patient. If you look at the cost, the one that is more, you take that here. So for the second question, it looks a bit similar to the first one, but there's a difference because this one is looking at the one or the cost that is most, that was borne by which of the following options. Again, if it's not there, you fill in the box here. So this particular question is coming off of where it doesn't specify if a patient has paid any part of their care. So this is asking, did the patient pay any part of their care out of pocket? Did they pay themselves? You click yes or no if you don't know. And if they are paying for their care, which area or which part of the care they received are they paying out of pocket? So is it just for the operation, or is it for bed? Is it for medication? Whatever it is, you select it from here. And then we ask for the total cost of care that they received. You put that in a box here in numbers. And then of that cost, how much was borne by the patient? And then also we ask for patient's income, monthly income if they are working, and then where they went, their discharge destination. Did they go home? Were they referred to a different facility, etc. And then the last bits of question is asking about the employment status of a patient employed or not. And if they are working, how many days did they get off work, or how many days did they miss off their normal working activity? Now, we are asking these information because we need to calculate what we call the catastrophic expenditure, and we need all this information to calculate that. And that's why we are asking for this in the finance sub-study. So like we've mentioned previously, the mini teams, you'd have mini teams for the cohort study, and then also dedicated mini teams for the sub-studies, so that they can just concentrate only on the sub-study and collect those data. In the morning session, there were questions about, can it be the same team in the main cohort study and then the sub-study? It depends on the hospital lead. I mean, if the same people who are taking data for the sub-study can take it for the cohort study, that's fine. So I'll leave this here and then pause for any questions that anyone might have. If there's anything that's resounding from the chat, please, the opt team members, please let us know so we can just answer it here. A couple of people have raised their hands. Please unmute yourself and speak.
Teddy.
Yeah, Maria.
From the chat, can you just show again that table that shows the registration of mini teams and the data collection periods?
Okay,
so
okay.
Up until when people can register their teams.
Okay, all right. Excellent.
Please.
Okay, so I was going to come to so this slide is really a timetable of when we will be issuing logins to.
Sorry, I think we are not seeing your screen. Sorry.
Oops, sorry. Okay, 1 minute. Can you see my screen now?
Yeah, thanks.
Okay, all right. So this for this cohort study, we are trying to structure things a bit more, and we'll be issuing mini team registrations on specific dates. What that means is that hospital leads need to have filled in the details of their collaborators before that date. So for instance, for the second period, which starts from the 17th of February to 2nd of March, we will be issuing the logins on the 9th of February. So between 9th and 16th, we'll be issuing logins. So that means that if hospital leads have entered the details of the collaborators before the 9th of February, then those collaborators would receive their logins within 9th to 16th. Now, in case you don't receive your logins because it wasn't entered before the 9th, that's fine. It's not the end of the world. What that means is that when we are ready to issue the logins for 3rd March, this period number 3, we would issue those that were not issued for the 2nd period, along with those we are issuing for the 3rd period. So if you are supposed to collect data for a particular period, but you don't have your logins for that period, you simply just collect the data on the paper CRF and then transfer it onto REDCap once you have your logins. So like Mohammed said earlier on, you need to note exactly the number so you can go back to those patients when you need to update any information. Now, regarding registration, as in expressing interest or adding new hospitals to the data, we are going to the project. We are going to open that until the first week of May. So our last data collection period is from 12th May to 25th May. We will close registration for new people to register for the study. We'll close that registration on the 1st of May. So if you haven't registered on the 1st of May, or if you have a colleague in another hospital who hasn't registered for the 1st of May, the project will be closed. Because the reason being that there is highly unlikely that you'd register on the 1st of May and get all your ethics and everything sorted out and get your logins and everything sorted out before the data collection actually starts on the 12th of May. I hope that is clear.
Thanks, Teddy. Do you want me to like call all the people that have like
Yes, please.
hand?
Yes, please. It's
Okay.
difficult for me to see on the screen.
Yeah. So the first one that I have here is Derek.
Yeah, good evening, and thank you very much for inviting us here. I've got few questions here.
Yeah.
In terms of entering a co-leader, not a part of the a co-leader, can we still enter the co-leaders at this stage?
That's the first question. The second question?
Yeah, the second question then, just define what do you mean so that, I mean, there's no confusion. Knife to skin, is that the operation time from the beginning when you insert your port up till the time you suture the port side? Just define that. And then my last question, total cost of care. You know, do you still want us to put total cost of care if the funder is exclusively government? This is a public hospital, the government who's funding the cost. Do we still need to put that a figure? Thank you very much. I'll listen on the radio.
All right. Thank you. Thank you very much. Yes. So first question, yes, you can add co-leads. You can add co-leads on the mini team registration now. It's not a problem, but it would be good to alert us in an email to say, I've added this person as a co-lead. The reason being that for people who registered first and registered hospital leads and co-leads, they were pushed through the system as leads together. If you registered initially as the only lead and you add a new person to you as the co-lead, we will get them in the system anyway. We'll issue logins to both the lead and the co-lead anyways, but it will be good to alert us in an email so we note that down, if that makes sense. And then
can you do that through the red cap? You know, we couldn't see the functionality. You know, we log into the red cap. We're not sure now because there is no option to add the co-lead. There are a lot of options to add people as on the mini teams, not but as co-leaders.
No, so on the mini team registration portal, there is I'm just going to show you quickly now. On the mini teams registration portal, there is the option to add a co-lead to that. So for instance, I'll just go here, it's quicker. So if you come here, your hospital will load up normally, or whatever your hospital is would come up based on what you entered when you registered, and your patient group will come up as well. And then you need to select what your study approvals are, and then consultants lead information, and the next one is co-lead information. So it will definitely be on the mini team registration portal, the hospital lead. So if you are now entering a co-lead, so if you initially entered yourself as the only lead for your center and you now want to add a co-lead, you have the option to add a co-lead here. And at the same time, you can fill in the options for your collaborators. So it's not too late for that. I'm just saying.
Thank you very much. Thank you very much. I think we missed that together with our research administrator. Thank you.
No, all right, that's fine.
It looks straightforward. Thank you.
Yeah, it is. The next thing is you asked about definition of knife to skin. So knife to skin is just like you said, when the time you put the knife on the skin, whether it's open or laparoscopic, when you were putting your port, once you make that incision, that is your starting time, and your skin is when you put in the last suture to close the skin, be it a port or a normal skin incision for open procedure. Now, I said earlier on that we would add a data dictionary to allow or to enable collaborators to actually collect this data. So in this data dictionary, we specify exactly what all these things mean. Your third question was on
government funder was exclusively funded by the
it was on total cost per patient. If it is government funded, we still want to know the cost, because the hospital would normally generate a cost for each patient, and each patient's pathway complications will be different. So it will be good to capture these. If a patient stayed longer because they had surgical site infection, the cost associated with their care would be different for somebody who had a straightforward appendicectomy and then went home the next day. So yes, please capture that information. Thank you. Yeah, Maria,
Yeah,
please.
noted.
Next.
Yeah, perfect. So next person that I have here is, I'm sorry if I'm saying this wrongly, Nityanand Jain.
Yeah, hey, it's perfect. Thank you for this very informative session. So I had 4 questions in total. 2 of them are related to the sub-study. So at the moment we did apply, like in the registration, we applied that we will participate, but it is based on ethics approval, whether we get it or not. So is it possible, like if later on we don't get the approval for this sub-study, we just participate in the main one and remove participation from this sub-study? For the sustainability one, because we are from Europe.
Okay.
The second question I was discussing with Maria, I think, but it got lost in the chat. Like, we will try not to have any skips between those 10 consecutive patients in the sub-study. But is there a minimum number of acceptable skips? Because, you know, sometimes patients don't consent to that data being collected. So I want to understand if there is some maximum number that you can tolerate in terms of skipping in the main study as well as in the sub-study. And then I have 2 questions related to the authorship. So in the main paper, do the leads and co-leads of the hospital need to be also registered as part of mini teams for them to be getting authorship, or they are automatically granted authorship apart from the mini teams? And the same question goes for the sustainability sub-study. Like, do the lead and co-lead will be mentioned as authors in the main paper, regardless of whether they are part of the 3-people team in the sub-study, or they need to be also part of those 3 people to be counted in authorship?
Okay, all right. Thank you. Thank you. So your first question, actually the answer to all your questions are yes, 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 yes. The first question, yes, you can take part in the main cohort study without taking part in the sub-study. They are mutually exclusive. So even if you don't get ethics eventually for the sub-study, it's okay to go on with the main cohort study. To your second question, so the 10 consecutive patients would be 10 consecutive patients according to local approval. So if you locally, you require consent to take part in, to undertake the sub-study, then it will be 10 consecutive patients who have consented to take part in the study, if that makes sense. So for instance, if you had first patient, it's okay. Second patient did not consent. Third patient did not consent, your fourth patient consented, then your first and your fourth patient are consecutive patients because they are consecutive eligible patients for the sub-study, if that makes sense.
Yeah, that
And
makes perfect sense, yeah.
Yeah, and your third question was about lead and co-lead. So lead and being a lead and being a co-lead, you don't need to be part of the data collectors to be granted authorship. So your authorship is irrespective of you collecting data, and it's the same for the sub-study. So a lead for a hospital, a lead and co-lead for the hospital are automatic authors, co-authors on the papers that come from the sustainability bits and then the main cohort study, if they contributed patients to those. So if you are lead, co-lead for sustainability sub-study, but don't contribute any patient at all to it, then you can't be a co-author on any paper that comes from that bit of study.
But how do we separate co-leads and leads for this sub-study? Because in the REDCap form, it's just mentioned on the top for the lead and the co-lead ones, and then it just goes on with the sustainability.
So the lead and co-lead are leads for the hospital.
Yeah.
So they are leads for both main study and sub-study.
Okay, so they would be listed irrespective whether they are working with whether they're collecting data or not. So that means for sub-study, basically we could have a team of 5 people, the 2 lead, the hospital lead and co-lead, and 3 data collectors.
Excellent.
Okay, all right, thanks.
Nice.
Okay,
Yeah, Maria.
perfect. Next person, Ed. Oh, can I just add up on that? Of course, if the whole team doesn't include any patients and no data is entered, then of course no one from the team will be listed in authorship. Just to be fully clarified on that. But as soon as someone in your team have entered data, of course the lead and co-lead will be automatically included. So next,
Sorry, I'm sorry, Maria. That just brings one short question. About these 10 consecutive patients who are eligible, what if we are not able to reach 10 patients who consent? Is there a problem? Because in the protocol, it was mentioned 5 to 10 patients, if I remember, that can be consecutively eligible. So do we take 5 to 10, or is 10 the new bare minimum number?
So yeah, it's 5 to 10. So 5 is the minimum.
Okay, thanks.
Yeah.
Okay, so next is sorry, Asala Senanayake, please.
Yeah, hi. Thanks. Can you hear me?
Yes, we can hear you.
Yeah, hi, Teddy. I think I have one of your colleagues working with me, Da Costa, and he's been talking a lot about you. So it's good to finally see you.
Right.
My questions, I think some of them were actually answered previously. Just to clarify, we have some more participants who like to join as mini team collaborators. And I understand there's no actual deadline per se for the period. So if we manage to register them before the first period, the ones for the first period should be all right, isn't it?
Yes.
Yes, okay. And in the form, for each period, you need to name your team. If the same team is going to do another period, you still have to enter all those details, or does it need to be re-entered over and over again?
Yes, you need to enter, just copy and paste it in the mini team form. So what would happen is, if it's the same team that is collecting data for all periods, when we issue the first login, we are not going to issue them another login again. They would use the same logins they had previously to continue filling the forms. We only issue logins for new collaborators who haven't already been issued logins.
Got it. One more question. Now we're waiting for the ethics and the clearance. But in the meantime, you said we can start collecting data on the CRF forms. So I just need to get information on how to access the CRF form. I still haven't got an email on it.
Okay, so we have the CRF form on the website. It comes with all the other forms. So I think we'll pop that into the chat, and then you can just easily download it from the website.
That's fine. Then just one more question. If
sure,
the guys who are collecting data will be their login information will be slightly different from the hospital leads, is it? The amount of access, they'll be given access only to enter data. Is that right? Or
yeah, they'll be given access only to enter data and edit data as well. And the hospital lead and the co-lead will also be given similar access to have to the data, because you oversee the data collection.
Right. So that data, the login permission, will it be limited at a certain point after the finishing of collection of data?
Yes. So if you're asking this because perhaps you want to see your hospital data, or do something with your hospital data at the end of the study, you can request for that, and then we'll make that available to you.
Right. Okay. Thank you so much. Thanks.
All right. No worries.
Okay, perfect. Next person I have here is Matlu Mabitsela.
Thank you, Maria. Yes, I think this is a follow-up question to Derek's question regarding the registration of core leads. So for our side, we already have a lead and a core lead, and we'll be participating also on sub-studies. So can we still add a core lead for participation in those sub-studies? I think that's the reason why we can't find an option to add a core lead on RedCap. Thank you.
Okay, so there is one hospital lead and one co-lead. So just the two leads, and they are responsible for both the main data collection and then also the sub-study. You can have 3 collaborators for the sub-study and then 3 collaborators for the main study in the different periods. But you can't have an extra co-lead in addition to the 2 that's already there, if that makes sense. So if it's about, maybe you can decide amongst yourself, if you want to maybe regulate what's happening, you can say, okay, maybe the co-lead takes care of the sub-study and then the main lead takes care of the main study. Whichever case or whichever arrangement you decide to do internally, both the co-lead and the lead would be recognized in both the main study and the sub-study as well. But then you can have an additional lead for the the sub-study. I hope that's clear.
Yes, crystal clear. Thank you.
Thanks.
Okay, perfect. Thank you. Next one, Hamed Syed Abdul.
Hello, Teddy. Hello, Maria. I hope you are doing well. I have about 2 questions. In comorbidities, what if a patient has no comorbidities? Should be an option of no. Is it there or not?
Okay, so first question, yeah. Second question, please.
Second question, in many teams registration, there is a new icon which is named login status, which is not abled, and it is disabled. What about it?
Okay, all right.
Third question. Sorry.
Yeah, third question. Okay, yeah.
What if one of the options that was asked for the patient is not filled? There will be a problem or not?
What do you mean? Which options, please?
In the data about the patients, what if one option or 2 of them comorbidities, interoperative, anything of the data about the patients were not there or missing or anything, the patient is included or not, or will be a problem?
Okay, I mean, so for most of the questions, there will be an option of none of the above or other, in which case you'd select what is appropriate. So I'm answering from your last question. So you mentioned about comorbidities. There's an option for none of the above, as you can see here. So if the patient doesn't have any comorbidities, just take none of the above. Your second question was, sorry, remind me your second question again.
The login status in the main team registration, login status.
So yeah, so that's actually something that's meant for the admin team here. So just forget about it. We'll hide that option, so you don't even see it. So it would probably not allow you to edit it, but that's fine. It's designed like that.
Okay, thank you. And about the missing information about the patients.
Yeah, so I was saying if you don't have that information, you either take none of the above or other, and then fill whatever it is. If absolutely not there, you don't have that information, you leave it.
Okay, thank you very much. I appreciate it.
All right.
Okay, thank you. Next one, Jody Ramadan, please.
Hello, everyone. I have 2 questions. The first one is, what if a data collector from a period didn't get to collect any data? For example, if during the period you have 3 data collectors and you have only 2 patients, is that one data collector is going to be disqualified for the authorship? That's the first question. The second question is, for example, if a data collector from period 1, for example, happens to be in the hospital for period 2, can they take data for the people from period 2, even if they are not registered for the period 2. And thank you.
All right, thank you very much. So the local management of data collection, the local people who oversee data collection is the hospital lead and the co-lead. So if the hospital lead and co-lead at the end of the day say that, okay, for instance, they put down 3 names as people to collect data, and at the end of the day, only one person does all the work, the other 2 don't do the work. When it comes to authorship, is the job or the duty of the lead and co-lead to give us the details of people who contributed to the study. There's no way we'll be able to know that it will be the job of the hospital lead and the co-lead when they are filling in the authorship form to indicate who contributed patients or not, if that makes sense. I hope that answers your question.
It does.
Now, regarding who collects the data, same is something that the hospital leads and co-lead would need to organize and decide. So, for instance, if you have 3 collaborators who are registered, 2 of them are on night, but they are supposed to be in, say, period 1, but they are on night duty and they are not there, and somebody else is around, but it's part of your data collectors. I think it's a local arrangement you need to make to ensure that every patient is captured, and then you in the end indicate who actually contributed to the study, and then we recognize those people.
That's clear. Thank you.
All right, thanks.
Okay, thank you. And Dimitri.
Yes, thank you, everyone. Really great to see so many people online. I think at one point we had 326 people, which is really amazing, particularly as we already had over 200 people online earlier this morning. So thank you, everyone, for joining. I just wanted to address a question that's come up in the chat a lot, if that's okay, Teddy.
Yeah, sure.
And there's a question there about, what's the minimum number of patients we're going to enter? And I just wanted to outline that it is really important that there are 2 things that are really important. One is that we get as diverse a selection of hospitals in this study as possible. So there are some hospitals that maybe do 20 or 30 appendicectomies a week, and that's a really high volume for appendicectomy. And it's important that we get those hospitals. But it's also important that we get the hospitals that maybe only do 1 appendicectomy a week, because there is variation around the world, and if we want our data to reflect the variety of hospitals where patients get their care, it's important that we get a variety of hospitals taking part in the study. So the answer is, if it's the case that you only have 1 or 2 or 3 appendicectomies a week in your hospital, yes, you definitely can take part in the study, and we welcome you to take part in the study, and that's really important. But the second point is, it's also really important that we capture all consecutive patients who are eligible during your selected study period. We can't pick and mix patients. We can't say, well, there were these 3 patients that were operated, so we'll include them, but the other 2 patients that were operated don't feel like including them for some reason. That is not good, because the robustness of our data, of our study, and its quality, and how accurate our findings are to guide patient care are very much based on the importance of collecting consecutive patient data. If we don't have consecutive patient data, we can get issues with bias coming in, because maybe we only collected the patients that were operated during the day and not during the night, or maybe we only collected the patients who had a good outcome and not the patients that had a bad outcome, or the patients who did or didn't perforate, and so on. So it's really important that we collect data on all the patients so that our final data set represents the true diversity of what goes on around the world. So to kind of put that together, if it's the case that you only have one patient operated during the study period, and you've checked really carefully, you've looked everywhere, and that's the only patient that had appendicectomy, that's absolutely fine. But if you had 10 patients that had an appendicectomy, you have to include all 10. If you had 20 patients that had an appendicectomy, you have to include all 20. So it's not the number of patients that's important, it's the fact that you're including consecutive patients. Now, I'm sure all of you want to take part because you think it's really important to do research and generate this global data. This will be a unique study for the first time, giving an insight into what happens in terms of appendicectomy around the world. But if somebody deliberately did not include all consecutive patients because they didn't feel like including all of them, well, I think that's just quite sad, really, because they're not making a full effort to take part in the study, and they're letting down everyone else who is making that effort. So I'd really ask you to this isn't about doing the minimum work possible. This is about making sure that we do a robust study that really represents what goes on around the world. So I think that's really positive. But I just wanted to address that because there were lots of questions in the chat. Does that sound okay, Teddy?
Yeah, that sounds brilliant. Thanks, Dimitri.
Okay, we have one more person that raised his hand. So Biruk Bekele.
Hi, everyone. Thank you for the very informative session. I just had a question regarding the collection of data on the sub-study topic. You've mentioned that the patient should be consecutive. And so if we have three data collectors collecting data differently, is there a way that we can, it might be a bit difficult to know for sure that the patients are consecutive, but do we mean when something, are we referring to consecutiveness based on the data collectors, or is it generally like the order of patients in the hospitals?
Okay, what's your next question?
Just one question.
Okay, all right. Okay, so consecutive in the sense that so data collection is starting on Monday. You have your first patient on Monday. You have your next patient on Tuesday, next patient on Wednesday. So these patients should be consecutively included in the study. Now, what that requires is communication between the teams. So the three people need to communicate amongst themselves and decide, okay, the three of us are taking for sub-study. So maybe I will take this day, you take that day, and you take that day. So it's the duty really of the hospital lead and co-lead to actually organize this and make sure that consecutive patients are captured. If you leave data collaborators or those taking the data to just sort things out or just pick up data any when or when they can, then that is when we end up missing patients. So there should be, if I were a hospital lead or co-lead, I would organize a rota for those collecting the data to make sure that patients who are captured within that time frame or patients who present within that time frame have their data collected, if that makes sense.
Yes, perfect. One a sub question to that question would be the form access. So the ones that participate as collaborators in the main study, they have access to the main questions, but the ones that only register as sustainability part of the study would only be able to access the sustainability form. So would there be an issue regarding how it's filled, which patient?
Oh, okay, all right, good question. So the sustainability. So if you're so it comes back to the point about communication. So if the hospital lead and co-lead have communicated to all their data collectors to say that we are taking part in the main cohort study and also the sub-study, that means that anybody who is entering data for, say, patient number 28, once you start that data collection process, one of the first questions it will ask you is, are you part of the sustainability sub-study? And the answer to that is yes. Once you click on yes for that particular question, that opens up the sustainability bit for you later on down. So if you're a data collector and your job is just for the sustainability bit, you skip everything else and then you just go straight to the sustainability bit and fill it. If you're a data collector for the main cohort study, you just fill your bit as main data collector, and then that's it. So everybody fills their portion, but then you all have access to the same data collection form.
All right, thank you.
Yeah.
Okay, thank you. Next person, Cassiana Lemos.
Hello, everyone. I have a question about if it's possible use a RedCap app to collect data. What I want to say, I can collect offline in a tablet and after upload in the main platform, or we don't have access to the app, because I know that there is some configurations on the RedCap that you can available the app or not with QR code. And I'd like to know if I have to access the main platform or if I can use the app on the cell phone, on the iPad. That's the question.
Yeah, I think you should be able to use the mobile platform to collect the data and offline and then upload it later on. It should be possible. Yeah.
Okay. And another question is about the sub-study. It's an option. I can choose if I will participate in a sustainability study. Yeah.
Yeah.
Okay. Okay. Thank you so much.
Which country are you from, please?
Brazil.
Brazil. Okay. Yes. So yeah, you have access to. So everyone has access to the sustainability one, but for the finance one is only for specific countries, including Mexico.
Okay. Okay. Perfect. Thank you so much.
Okay.
Welcome.
Thank you. Next person I have here is
Hello.
Lina Al-Kazili.
Hello.
Hello. Thank you for this informative session. But I want to ask, we need to collect consecutive cases. What if one or two got missing for any reason, that got discharged early? We couldn't collect data properly. Would it make the data collection period invalid? That's my first question.
Yeah, so good question. Thank you very much. So the ways of collecting data could be from the patient records. So even if the patient was admitted, had their operation by someone in the hospital, and then was discharged early before any collaborator met them, they can get the information, they can get whatever information else they can get from the patient's records. We can get that.
Could we collect the data? This means that the data that we can enter into the questionnaire can be collected at the morning, not necessarily we should be present at the time of operation to collect especially the intraoperative data.
So that is a very good question. So for the intraoperative data, and that's what most that's where most of the sustainability work or data points are. What I would suggest, or what some other hospital leads are thinking of doing, which I think might be helpful, is you can get in touch with whoever it's anyone in theater with the CRF for that particular, for the sustainability bits, and then they can take the areas, even if you are not personally in theater. That's one of the tasks to do as a lead or as a collaborator, to get somebody, even if you are not present. So for instance, if the operation happened at night and you were not there, one of the things you can do is to leave the form for somebody else to fill in the bits that were used, whatever was used in theater. And when you come back, you take that and then you upload it onto RedCap.
Okay, thank you so much.
Thank you.
Thank you. We have someone that couldn't put his hand up, but he asked me in the chat to speak. So Dr. Diraj Malik.
Okay, hello. Yeah,
Hi.
Am I audible? Hello?
Yes, we can hear you.
Okay. So I need to know one thing. I just came across in the website about the data sharing consent. So
Yeah.
should we have to fill it and send it to you before the study starts?
Okay, thank you very much. I was going to come to that shortly. So with the data sharing agreement or data transfer agreement or data usage agreement, whichever term is used in your specific setting, it is according to what is required locally. So some people might need it, some people might not need it. It's just a section of people who need it. Don't feel that because it is on the website, you need to sign it and then send it to us. For some people, that is part of their normal approval for participation in the study. Many other people do not require DTA to be part of this cohort study. So if you don't need it, you don't need to sign it. But if your ethics department or is asking for it, then yes, we would ask that you sign that draft DTA and send it to us. That's something that a hospital lead or co-lead would do if it is needed, only if it is needed. Now, the thing with the DTA is we've had quite a number of DTAs that have come in. Now, the DTAs would normally, this is the process. When you send it to us, it goes to our legal department. Our legal department looks at it, signs it, and sends it back to you, and then you sign it and send it back to us. It takes a while, a long time. So if you don't need it, would say, or if it's not required for you to undertake the study, would ask you to just leave it. But if it's something that is required by your ethics department, then we would ask that you sign our draft DTA, send it to us because we have drafted it, or our legal department has drafted it. It takes a shorter time for them to go through and then sign it and then send it back to you, and then you can give to your ethics board. But if you have a special individual DTA or data sharing agreement, that is going to be very difficult for our legal department to go through the entire thing and then get it signed and send it back to you.
Okay, thank you so much. I just need to ask you one more query.
Yes, please.
During the data logins, during the end, just at the end of the study timeline, do we have to enter the data logins just on those times, especially the RedCap data entries? So should we be entering data just at the end of the study timeline?
So yes, you enter data within the periods that that has been stated. If I get your question right.
Yeah. Thank you so much. Okay.
All right.
Thank you. There is no more hands up, but Biruk Bekele, you had your hand up right like 5 seconds ago. Is that still a question or was it already answered?
I just wrote it in the chat, but it's regarding the consent forms. I was just wondering if it's a requirement to print the consent forms and then have the patients sign them directly, or if we can do something digitally, and then if it's required to print it, are we required to upload it at the end of the study? That was my question.
Okay, thank you very much. So the consent from, just like the DTA, is not a requirement for every center. Some centers don't require it at all. Actually, many centers don't require consent from a patient information sheet. We only added it for the few centers that would require it. Don't feel like once the consent form and the PIS are there, you have to use it. If you don't need a consent form for an audit, which is not needed in the UK for instance, you don't need to sign a consent form. If you do have to sign a consent form, that's fine. You don't need to send that consent form back to us.
Thank you.
All right, you're welcome.
Okay,
So,
perfect. I think there are no more questions, Teddy, at least from
Oh.
what I can see.
All right, excellent. So before we just wrap up in the next 3 to 5 minutes, I just wanted to introduce our Alligator ChatGPT. I think, Dimitri, if you're on and want to say something a bit about this, that would be great.
Yeah, thank you, Teddy. It's been a great session. Thank you, everyone, for joining and for all your comments and questions. I hope we've helped. Now, the idea of Alligator GPT is to use the ChatGPT technology to help you to get quick answers to your questions. So this isn't going to be perfect. It's not going to solve all your queries, but I think many of your queries, maybe 80%, can be addressed by it. So we'll share the link to this website. You will need to have a login for ChatGPT, but it's free to sign up. So once you're logged in and you're on the page, all you do is you ask a question, anything about Alligator, and using the information that we've trained Alligator GPT with, it will give you an answer if it can. If it can't answer you, it will tell you to send us an email. But I think for many questions, it will answer your questions faster than we can by email. That's it, really. I mean, the other thing is that there's a link there that you can go on to get to fill out an evaluation. So please, if you do use the Alligator GPT, do go on the evaluation sort of page and fill that out to give us your feedback and a few tips for how we can improve it. You can actually use this in other languages as well. I mean, I think we've tested it in French and Spanish maybe, but yeah, if you ask questions in other languages, it will try and interpret the information for you. I think for those of you who haven't yet filled out your ethics, you could try getting Alligator GPT to draft some of the answers to your ethics form. It might help you. But I would say that, of course, it's your responsibility to make sure that any ethics documentation you submit is accurate. So it's really just a tool to try and help you get answers more quickly. But if you have any feedback or comments on it, then please let us know.
Dimitri, can you just pass the this page of the Alligator GPT into the chat box, because some people are asking.
Teddy, I think Teddy's got the link to hand.
Oh yeah, I will.
Thank you.
Yeah, someone already. I think someone already passed it. Thank you. Thank you, Biruk. I think he already passed it. Thanks.
All right.
And sorry, just Teddy, before we begin, we end. There was just one other important point I wanted to make around ethics approvals and such. So the key thing is every country, every hospital has different requirements in terms of what approvals need to be in place to take part. So we can't give you detailed guidance on what the correct approvals for your particular situation are. You need to find that out and make sure they're in place. And it is your responsibility, particularly as a hospital lead, but even as a collaborator, to make sure that you have the right approvals in place to do that. Now, in terms of data collection, it's possible that you might get approval to start the study, but you haven't yet got approval to submit the data to REDCap, for example, if you need a data transfer agreement or something else. In that situation, you could start collecting data on the paper forms before you upload it onto REDCap. So you collect the data on the paper forms. Once you get permission to upload that data, you can upload it. what you shouldn't do, don't start collecting any data until you have been given permission by your hospital to collect data, or by your National Ethics Committee, or whatever the right body is. So just protect yourself by making sure you have the right approvals in place before you collect data. And you know, as I say, that's not something we can give you advice on, because that will be different everywhere. So that's just a quick kind of note on that, really. Any other points anyone wanted to raise, I guess? Maria, Teddy?
Yeah, I think that's excellent. Thanks, Dimitri, for highlighting that. I just tried this on Arabic. My Arabic is poorly today, so I can't really interpret what it's saying here. But I think it makes sense to me. If there are any other questions, please, our emails are there, and the hospital leads and the co-leads, please join the WhatsApp group. And yeah, we'll see you there. And like I said, we'll have like several other sessions based on regions. So this will not be the last session. So if you have any specific questions, we can also answer those there. Okay, in the absence of any other questions, we'll bring this meeting to a close. And thank you all very much for coming. And
thank you.
Thank you.
Sorry.
Bye-bye.
Thank you.
Thank you, Teddy. But thank you everyone for taking part. We're really grateful for your participation, and we really look forward to working with you.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.
thank you all very much. Thank you. Bye.